I was watching football with my friend. I remember my speech was slurred, and I stood up to use the bathroom, but next thing I know, I woke up in ICU. I had a massive stroke 3 years ago when I was 20 years old. Because I was so young, I didn't have the typical risk factors. A lot of college students don't know that it can happen to you, so awareness is so important to me. The acronym is FAST. F stands for face. You should check and see if the person has any drooping on one side of their face. A is for arm. Ask them to raise both of their arms and see if you see any drooping on one side. S is for speech. Check for any slurred speech. Then T is time to call 911 if you notice any of those. So you just have to remember that time lost is brain loss, and you have to get to the hospital fast. I was paralyzed on the entire left side of my body. I thought I was going to be in a wheelchair for the rest of my life. I found out I could get better. That's when I jumped into recovery mode. So I just did whatever I could to recover and just be me again. I really was doing my homework, going to therapy and doing it at home like twice a day, 3 times a day, as much as I could. I was in the wheelchair for the year. For my 1-year anniversary, I was walking and I did a 5K. On each 5K, I jump over the finish line because I'm so excited just to be walking again. Physically, I don't really look the same because of the paralysis, but it doesn't stop me. Like, I still travel like I want, still go out like I want. They've told me before that I will not be able to do things, and that hasn't stopped me. So whether they say my hand's not going to be 100%, that's not going to stop me from going to therapy and doing my exercises. It won't stop me from trying.
Hello and welcome to our community conversation on stroke. As you know, May is National Stroke Awareness Month, so today we will share with you about the warning signs and symptoms of stroke, preventative measures, and the rehabilitation and treatment of stroke. My name is Todd Brinton. I'm an interventional cardiologist and served on the faculty at Stanford for the last 20 years. I was a practicing clinical cardiologist until I made the decision to actually come to Edwards Life Sciences as the Chief Scientific Officer. I also have the pleasure of chairing this year's 2022 Heart of Orange County Heart Ball, which will take place on October 22nd, 2022. Edwards Life Sciences and the American Heart Association actually have a long history. In fact, it was back over 60 years ago in the founding of Edwards Life Sciences by Lowell Edwards and Dr. Starr, a cardiac surgeon at University of Oregon, the first artificial heart valve was actually conceived. And in fact, that heart valve was funded through research fundings and grants for the American Heart Association. So you can see there's been a long history between the American Heart Association and Edwards Life Sciences, and that continues on both a local Orange County basis, regional, as well as a national campaign. I would now like to take the opportunity to introduce our speaker for today's conversation, Dr. Mohommad Shafie, Associate Clinical Professor of Neurology, Associate Director at UCI's Health Comprehensive Stroke and Cerebrovascular Center. Thank you very much for being here, Dr. Shafie, and thank you to all of you for participating.
Good morning, everyone. So this morning I will be talking about stroke prevention, diagnosis, and treatment. Next slide, please. So the nutshell that I want you to take away from this talk is that stroke is an emergency, stroke treatment is time sensitive, and fortunately, up to 90% of strokes are preventable. Next slide, please. I will this morning take you in the next short few minutes through a whirlwind of what is stroke, what are the different stroke types, what are the different risk factors, and how health behaviors contribute to risk of stroke, and how to recognize the signs of stroke and the treatments that are currently available for stroke, and lastly, talk a little bit about the recovery process from stroke. Next slide, please. So, by simple definition, a stroke is when sudden onset of neurological symptoms uh, occur due to disruption of blood flow to a focal part of the brain. Majority of strokes are ischemic strokes where there is a clot that blocks the blood flow to an area of the brain, resulting in brain cells dying. The remainder of strokes collectively are called hemorrhagic strokes, in where there's bleeding that occurring inside or around the brain and ultimately resulting in brain cells dying and causing in neurological symptoms. For this talk this morning, I will focus on the more common type of stroke, which is ischemic stroke, as we go on. Next slide, please. So annually, there's about 800,000 people who experience an ischemic stroke every year. About a little over 600,000 of these folks have their first attacks or first strokes, and a little over 180,000 experience a recurrent stroke. In general, women have a higher lifetime risk of stroke than men. In 2018 to 2019, between 2.7 to 3.2% of US adult populations, that's people over age 18, reported to have had a stroke. And it is projected by 2030 that an additional 3.9% of US adult population will have had a stroke, which would be an increase of a little over 20% in prevalence of stroke compared to the previous decade. Next slide, please. So when we talk about stroke risk factors, in a big picture, we can divide the risk factors in two different groups. One are the non-modifiable risk factors, in which you have no control over that risk factor, including things like age, family history, or males having a greater risk of stroke. Now, the other group is the modifiable risk factors, in which you have control, and by controlling and staying on top of these risk factors, you can reduce your risk of having a stroke significantly. And some of these are listed here, but we'll get into more detail as we go through this talk this morning. Next, please. So I think from my perspective, the most significant risk factor for stroke is high blood pressure. And it is something that easily an individual can control and can stay on top of that risk factor. High blood pressure is a major risk factor for both ischemic and hemorrhagic stroke. And it's defined as systolic blood pressure, or top number being greater than 130, and diastolic, or the bottom number, being greater than 80. And unfortunately, for high blood pressure, most of the time it does not cause any symptoms. And when it does cause symptoms, it's too late. And unfortunately, people are end up in the emergency room being treated. There are data that show that up to 40% of US adults are even unaware that they have high blood pressure. So regular blood pressure screening, including home monitoring, is really critical for identifying and impacting early intervention. And high blood pressure should be treated with a combination of both lifestyle modification, including diet and exercise, as well as medical therapy to achieve the blood pressure goals. Next, please. When it comes to cholesterol, it is somewhat of a complicated association with risk of first ever stroke. In terms of different factors, different components of cholesterol, it's been shown that people with high levels of total cholesterol and LDL, or what I refer to as lousy cholesterol, are at a greater risk for ischemic stroke, whereas people who have low levels of these two components have a potentially increased risk of hemorrhagic stroke. So a fine line has to be walked to balance these two contributions. But essentially, diet and lifestyle changes are the first step in reducing stroke risk due to high cholesterol. However, statins should be considered in patients that are deemed high risk. And the decision making about statin treatment should consider individual patients' risk and preferences regarding potential risks and benefits. Next, please. So currently in the United States, 90 to 95% of those individuals with diabetes suffer from type 2 diabetes, which is an independent risk factor for ischemic stroke. And throughout this talk, when I refer to diabetes, I will be referring to type 2 diabetes. And type 2 diabetes confers a greater risk in patients younger than 65 years of age and women. So, in patients with diabetes, to prevent microvascular complications, it's recommended to maintain an A1C level of less than 7%. And again, there are data to support that further aggressive blood pressure reduction to a systolic blood pressure or top number less than 120 reduce the risk of any stroke by 41%. This is a evidence that these risk factors that we talk about, not only they're independently associated with increased risk, but to some extent they work synergistically to increase the risk of stroke in individuals. Next, please. So atrial fibrillation, which is a disorder of heart rhythm, or we refer to it as irregular heart rhythm, independently presents a 5 times greater risk of ischemic stroke. And it's noteworthy to mention that people who have a stroke due to atrial fibrillation often have more severe strokes and worse outcomes. And that's why it is a very significant risk factor for stroke, and we always screen for it and discuss it. So prevalence of atrial fibrillation also increases with age, and women are at higher risk of having a stroke due to atrial fibrillation. Fortunately, oral blood thinners, um, things in the old days that were including warfarin, and now with newer agents that I have listed here, have shown to significantly reduce the risk of stroke. However, again, there is data to support that atrial fibrillation is extremely undertreated in the population for various reasons that are beyond the scope of this talk. But the recommendation is that if someone has atrial fibrillation and no other risk factors that, or no other contraindications rather, they should be treated with oral blood thinners to reduce their risk of an ischemic stroke. Next, please. So this hopefully is a sort of a no-brainer that yes, cigarette smoking is bad for you. Cigarette smoking is a risk factor for both ischemic stroke and subarachnoid hemorrhage, which is a particular type of hemorrhagic stroke. People who are actively smoking increase their risk of stroke by 2 to 4 times, and secondhand smoke also increases your stroke risk by 25%. However, smoking cessation is effective in reducing risk of stroke, and smoking cessation is typically achieved through both counseling and in combination with medications. So, next slide, please. Again, we have evidence, plenty of evidence to show that physical activity has protective effect when it comes to reducing your risk factor for stroke. So physical inactivity is a risk factor for stroke, and we typically recommend that adults to accumulate activities consisting of at least 150 minutes per week of moderate intensity or 75 minutes per week of vigorous intensity, or a combination of that, of aerobic exercises, and at least 2 days per week of muscle strengthening. Next slide, please. In terms of diet, a diet typically rich in fruits and vegetables may be beneficial in reducing stroke risk. People have talked about the DASH diet and the Mediterranean diet that have been shown to potentially have a protective role. These diets typically emphasize fruits, vegetables, fish, and white meat, and are low in sodium and high in potassium. So next slide, please. For those who choose to drink alcohol, again, it should be noted that um, low to moderate amount of alcohol lowers risk of ischemic stroke. So by that, we typically mean one or less drink per day for women and one or two um, drinks per day for men. There's also an association between heavy alcohol use and hemorrhagic stroke. Um, but having said that, this low to moderate level of alcohol protects against ischemic stroke. That doesn't mean that we should encourage people who are not drinking to start drinking, and we should consider advising people who are drinking heavily to limit their alcohol consumption. Next, please. Now, on to how do I know that I'm having a stroke or someone that I know is having a stroke? When I would imagine if I tell all of you in the audience that I'm having chest pain, the first thing that would come to your mind would be that, oh, am I having a heart attack? Because it's fairly chest pain associated with heart attack. Next slide, please. But unfortunately, when it comes to stroke, stroke is a very heterogeneous disease. And by heterogeneous disease, I mean that there are many, many different potential causes that could result in stroke. And stroke in the same location in the brain in different individuals may result in slightly different symptoms, and symptoms may be very non-specific. So it's very difficult to pin down the signs and symptoms of stroke for a layperson, for instance. And so it's not a direct correlation between a symptom and onset of stroke. Next slide, please. However, over years, thanks to the American Heart and American Stroke Association, there have been campaigns such as FAST, where we talk about drooping of face on one side, weakness of the arm, or difficulty with speech, that are warning signs of stroke. And more recently, we have updated that to be fast, where we have included if a patient is balance, which means that if a patient is having sudden loss of balance, or eyes, if the person having a change in having a vision disturbance in one eye or both eyes, and the rest of face, arm, and speech difficulties. Again, once somebody, and you have to note that if somebody is having stroke signs and symptoms, they should call 911. That's the T, or time, stands for, because studies have shown that people delay their care and result in worse outcomes when they're not calling 911. Next slide, please. Now, in my practice, in addition to the be fast, I also add sort of this sudden seven stroke warning signs. That it starts with, if you're having sudden onset of confusion, or somebody is having sudden onset of confusion, if you're having sudden onset of severe headache without a cause, that is, the patient is, or a person is not a headachy person, but all of a sudden they have the worst headache of their life, those are also signs and symptoms that they should seek immediate medical attention, because not only we worry about ischemic stroke, but also hemorrhagic strokes, that now that we have advanced our understanding of stroke in all aspects, that we can potentially help them and improve their outcome. And then the reminder is the difficulty with balance. So somebody who has sudden onset of room spinning, dizziness, or vertigo should also seek care. And similarly, difficulty seeing, whether it's blurry vision or loss of vision in one eye in a sudden manner, should seek immediate attention. And then difficulty speaking, when and by speaking is a general term, but that includes things like understanding others and trying difficulty articulating your words and verbal expression, also going to that bucket. And sometimes people confuse that with confusion, that somebody's having difficulty speaking, they take that as the patient is confused. And that's why I put confusion on this list so that people are aware that, oh, my loved one appears confused, but in fact, they're just having a difficulty talking. And the last two are weakness or numbness. By weakness, it's meant that some people describe it as I feel heavy, I'm unable to move my arm, or I have poor coordination of movement of my arm, and or face and leg, that you see droopiness on the face, or can't move my leg and I'm dragging my leg. Numbness, again, it is yes, numbness, but also things such as tingling in my leg or arm or face also counts for that. Next slide, please. Um, so I would like to point this out, that the difference between women and men, that just like women sometimes present with atypical chest pain, in stroke world there's studies that have shown that women are more likely to present with non-traditional stroke symptoms. Again, these vary from headache to feeling funny, and having nausea or even hiccups, to um, uh, loss of consciousness, and a whole variety of different symptoms. So you should have a low threshold, uh, that not to be dismissive of symptoms that are sort of not traditional and don't fit the category of fast or be fast. Also, women are more likely to present with stroke mimics. These are neurological conditions that, or other conditions that present and manifest similar to a stroke. Like migraine patients often show up to emergency room, or sometimes with difficulty talking and moving one side of the body, as a manifestation of their migraine. But if we don't know that patient, we should think that that patient is experiencing a stroke, or patients with seizures or brain tumors, etc., that have these presentations that are not stroke, but they mimic stroke symptoms. Next slide, please. So, how do we treat stroke? So, there are two current treatments available for ischemic stroke, and both of them are focused on essentially removing or dissolving the clot in the blood vessel to restore blood flow to the brain. The mainstay of treatment is a pharmacological, it's a medication, it's a clot busting medication that we give through the vein. And This medication it's very time sensitive. It can only be given to patients up to 3 to 4.5 hours from time of symptom onset. And this medication has strict clinical criteria, because, after all, it's a clot busting medication or a blood thinner, and one of the risk factors is bleeding complications. So we, in when patients show up to the emergency room, we take our time and our due diligence to make sure that this patient does not meet any exclusion criteria when giving this medication. So, and it's only been around since 1995, so sort of a recent medication. So, a clot busting medication given through the vein, only available when you show up to the emergency room, between 3 to 4.5 hours. The sooner you receive the medication, the better the outcome. And that's been shown over and over in clinical trials and studies. Next slide, please. So the other method of getting rid of the clot in the blood vessel after you give clot busting medication, or in lieu of the clot busting medication, is a mechanical approach, where it's called an angiogram or a catheter approach, where by a wire through your blood vessels in your leg, you go all the way to the blood vessels in your head and neck. And as you can see on the image on the bottom left hand side, you try to either fish out this clot from your blood vessels, or suction it out. And at the end, you'll see the images on the right side, that you'll see the clot at the end of the device. And this procedure is typically reserved for people who have evidence of large clots on their imaging studies, and they are able to have areas of brain that we can salvage and they can recover from stroke. Uh, Typically, it's performed up to 24 hours from symptom onset, and it's this is something that's only become standard of care really up to 24 hours since 2018. But again, it's not to wait 24 hours before you start the procedure. The sooner you perform this procedure, the sooner patients receive this procedure, the better the long-term outcome. And multiple studies and trials have shown that sooner treatment is better. Next slide, please. So, yes, we have these treatments, but it's not as if you can show up to an emergency room and all of a sudden they give you this treatment at the door. Over the past 3 decades, we have really come a long way in developing stroke system of care. That's why we ask patients to call 911 to basically take you to the nearest designated comprehensive stroke center where physicians and nurses and staff can evaluate you, do imaging studies, do labs, and decide if you're a candidate for a clot busting medication. If you're a candidate clot busting medication, you receive the clot busting medication, are you still a candidate for a mechanical clot removal or not? And make those decisions in treatment and improve outcomes. Again, what we emphasize is time is brain. So this is a mantra that we have had in treatment of stroke because it's been sort of calculated based on mathematical models that every minute that you're experiencing a stroke, you're losing about 2 million neurons in your brain. Next slide, please. So based on 3 decades of improving stroke system of care, we have come a long way. That I remember when I was in medical school, stroke was the third leading cause of death in the United States. And as of 2013, 2014, stroke is now, we have reduced mortality in such that it's only the fifth leading cause of death in the United States. Um, However, stroke remains as a leading cause of long-term disability in the United States. And even despite our best efforts and all the treatments, only about 10% of patients with stroke fully recover and are left without any residual symptoms, and 50% are left with a severe residual disability. And this is all not only has the uh, cost and disability in terms of patients and their lives that are changed, but also has a huge burden of cost in our healthcare. That is between 2012 and 2030, the total direct medical stroke related costs are projected to triple from 71.6 to $184 billion. Next slide, please. When it comes to recovery, I want you to understand that recovery from stroke, we compare it to, it's not a sprint, it's a marathon. So we talk about weeks, months, and a year or so after stroke. Rehabilitation services are usually the primary mechanism in achieving functional recovery and independence. A whole host of services, including speech, language therapy, occupational therapy, and physical therapy in varying quantities and durations over different settings and over time, should be provided. But unfortunately, most patients with stroke do not even receive acute rehabilitation therapies. And many who do are left with substantial residual disabilities. Next slide, please. So, in summary, I'd like to point out that, again, up to 90% of strokes are preventable. Among many risk factors, I urge you that high blood pressure is a major risk factor for both ischemic and hemorrhagic strokes. So, periodic home monitoring of blood pressure and screening and treatment, if needed, would be the most effective way that you could significantly reduce your risk of stroke. Acute treatments of stroke are available, but they're very time sensitive. So if you or someone you know is suspected to be experiencing a stroke, the best thing is to call 911 so that they are taken to the nearest designated comprehensive stroke center where they can receive appropriate therapy. And lastly, remember, Stroke is an emergency, and time, every single minute counts, and time is brain. And remember, next slide, please, that the warning signs of stroke, anybody, the be fast sign, and on top of that, the confusion and severe headache without a cause, you should immediately call 911. And next slide, please. And that's all. So I thank you for paying attention, and I'll take any questions, I suppose.
Knowing the warning signs of a stroke may be the difference between recovery and disability. Symptoms are sudden numbness or weakness of face, arm, or leg, sudden confusion, trouble speaking or understanding speech, sudden trouble seeing in one or both eyes, and sudden trouble walking, dizziness, or sudden severe headache. If someone shows any one of these symptoms, call 911. FAST is an easy way to remember the signs of stroke: facial droop, arm weakness, slurred speech. Time to call 911.